osteoarthritis? Unfortunately, it's multifactorial, meaning there's a lot of different things. And for some patients, some of these factors are in play and for others not. Such as excessive wear of joints, that's pretty much the main cause for all patients. Somehow, some way, you're getting an excessive wear of the inside of your knee joint, and that's the cause of your osteoarthritis. It may be related to injuries from sports or other activities. It might be related to a work-related injury. How about age? Certainly age plays a factor, but interestingly enough, not all people get osteoarthritis as they get older. Genetics plays a significant part in some people's osteoarthritis, but not everybody. So there's patients who they're the only patient in their extended family that's ever had a problem, and there's other patients where everybody in the family has had arthritis. Obesity is not the cause of arthritis, but especially in the knees, it tends to accelerate our osteoarthritic wear. And any type of deformity that you have within your joint, anything that makes a joint irregular or out of alignment, tends to accelerate osteoarthritis. So let's go over a little anatomy here. So you have into your thigh bone, top of your shin bone, your kneecap. So the lower end of your thigh bone is covered by a nice white, what we call articular cartilage. That's on the end of the thigh bone. It's underneath your kneecap here, as well as on the top of your shin bone. It's that articular cartilage that gets damaged when you have osteoarthritis. It's the wearing off of that white, shiny bearing surface is what the basic problem is. In addition to the cartilage on the ends of the bone, you have the ligaments. Ligaments are structures, or think of them as straps kind of holding the knee in place. You have a lateral collateral ligament on the outside of your knee, a medial collateral ligament on the inside of your knee. So many times in football, you may see on a sports page, somebody had an MCL injury that's spraining your medial collateral ligament. So we see the patella on the front here, which you don't realize is behind it, it's actually running in a groove on the end of your thigh bone. And both of those surfaces have cartilage, and that groove is important because it helps stabilize the kneecap in the center of the knee, which helps stabilize your thigh muscle and makes the knee flex and extend properly. The knee is a complicated hinge joint, and adding further sort of complexity to the knee is the meniscus, which are these two C-shaped structures that sit here. It's the meniscus that people refer to when they say, oh, I have a torn cartilage in my knee. They're referring to the meniscus, which sits in between the joints. And lastly, we have your ACL and PCL, which is anterior and posterior cruciate ligaments. So your anterior cruciate ligament is the main ligament inside your knee. Cruciate meaning cross, so these two ligaments cross inside the knee. And your ACL, again, is another commonly torn ligament in sports injuries. So that's the basic anatomy of the knee. And in osteoarthritis, what happens is that white bearing surface, that white articular cartilage on the surface of the bone, gets worn off. So let's talk about the disease progression, that is the progression of osteoarthritis. In the beginning, you really may have no symptoms of osteoarthritis. You might have fallen and hurt your knee, and you show up in the office, and it turns out that we can see the early beginnings of arthritic change in the knee. The Arthritis Foundation has produced some data showing that most people over 60 years old have some degree of arthritic change on their x-ray, but only a third of those patients actually have symptoms. So a lot of patients wonder, how could I have arthritis if I was fine 2 days ago? So that's not uncommon. They've actually had symptoms and had changes on your x-ray, but no real symptoms. So as time goes on, the surface of the smooth cartilage covering the bone tends to soften, and then that cartilage begins to lose its ability to absorb the impact of your normal daily activity and becomes more easily damaged. So what goes on, what previously we saw in here, as far as the space between the bones, you hear people talking about bone on bone. What happens is as you get arthritic change, that space becomes more narrow. That is, as you wear the cartilage away, these bones are allowed to get closer and closer. As we get to more severe arthritic changes, large sections of the cartilage may be gone to the point where you are bone on bone, and the joint may lose its normal shape and alignment. You can also tend to form spurs, what we call osteophytes. Those are growths of bone along the edge of the joint. And in addition to spurs, many times with the arthritis, you can actually form cysts within the bone. That's all part of the arthritic process. So now we've covered some of the basics of what osteoarthritis is. We'll talk about non-surgical options, and we've covered these in previous talks, so I'll just kind of run through them. lifestyle modification, that is modifying what you do, weight control, exercise, therapy, medications, cortisone injections, gel injections, bracing. So let's just talk about exercise and weight control. So research has shown that exercise is one of the best treatments for osteoarthritis. Exercise can decrease the pain of arthritis. It certainly can improve flexibility, and also will help you maintain weight. But what's key is a healthy diet can facilitate weight loss, resulting in reduced stress on your knee and your weight-bearing joints. That's very important. What about heat and cold? Patients ask frequently, should I ice my knee, put heat on it? Patients use warm baths, hot packs, cold packs, ice, very elaborate icing machines. Typically we tell patients use heat to loosen up and ice to decrease inflammation either after activity or at the end of the day. Medications. This is the list of medications that are typically used in osteoarthritis. So acetaminophen, Tylenol, non-steroidal anti-inflammatories. That's a large category of drugs that over-the-counter versions are things like Advil and Aleve. Prescription ones that would be like Celebrex. And then there's topical creams and sprays. Narcotic painkillers we stay away from in treating osteoarthritis since it's a chronic disease. Corticosteroids, those are cortisone injections. In osteoarthritis, we tend not to treat osteoarthritis with cortisone pills. Hyaluronic acid, that relates to the gel injections we do. We can talk about that in the next slide. But be aware that many medicines that are used to treat osteoarthritis, in addition to the fact that they may benefit you, they may have significant side effects. So as with all medications, you should understand what those are. So gel injections, which is called joint fluid therapy. We do thousands and thousands of gel injections a year. It's a treatment to treat the pain of osteoarthritis. In some patients, it provides long-lasting relief, but in some patients, they get no relief. So for some patients, I think it's terrific, and others, I think it was a waste of time and money. But what we're doing is injecting a substance called hyaluronic acid into the knee. That hyaluronic acid is similar to your normal joint fluid called the synovial fluid, which helps lubricate the knee and decrease pain within the knee. So those are, in general, the non-operative options. So let's talk about surgical solutions. We spoke here a number of months ago about stem cell treatment for osteoarthritis in the knee, where I draw some blood from the top of your hip area here, concentrate that, and inject your stem cells into the knee joint. That's an investigational procedure. It is also probably more appropriate for smooth, mild, moderate arthritis. And that's just what we're showing here, how we're taking the various stem cells, derived tissues, and then we concentrate those all with the hope of regenerating some tissue. We previously spoke here about subchondroplasty. In many patients who have bad arthritis in the knee, in addition to the arthritic wear on the surface of the bones, underneath the cartilage, that bone is seeing a lot of abnormal stress. And it gets what we call bone marrow edema. Bone marrow edema, the easiest way to think of it, is almost like a stress fracture in the bone. And if non-operative measures don't relieve the pain from this, and this can produce severe aching pain, if non-operative measures don't relieve it, there's a procedure where we inject a bone mineral substance into that area to support that damaged bone and relieve the pain. What's another surgical procedure that we use in osteoarthritis? Partial knee replacement. Partial knee replacement is a great operation. If somebody has arthritis that's limited to just one portion of their knee, we simply replace that portion of the knee and nothing else. What's the advantage of partial knee replacement? It's a more minimally invasive operation. It's a little easier to get over than a full knee replacement, and it feels a little bit more like a normal knee. The downside of a partial knee replacement is that most patients don't come in with just arthritis in only one part of their knee. Most patients come in with a little arthritis here, a little arthritis there, a lot of arthritis there, so they're not candidates for it. But we're always, when we're evaluating people, we always look at these kinds of issues. So that brings us to total knee replacement. So for most patients who've gotten past non-operative measures and are considering surgery for arthritis in the knee, we're talking about knee replacement. And what's done is we take your arthritic knee, prepare the bone, and in its place, finish it with metal and plastic, trying to create a new bearing surface for the knee. So if we think about the end of your thigh bone, top of your shin bone, those bearing surfaces are rough and painful. Almost think of them as two blisters rubbing on each other. So we reshape the end of the thigh bone, shave off that arthritic painful surface, and we prepare it in a fashion that will correspond to the metal component that's part of your knee replacement. That metal component is then cemented into place to fix it in place. Same thing on the top of your shin bone. We shave off the arthritic top of your shin bone, and we prepare it to accept what we call your tibial component, which is a metal tray that fits on top of that. So we're showing here the metal tray, and that has a plastic insert that fits into the metal tray, and then the metal on the end of your thigh bone actually rides on plastic. What's not shown here is also your kneecap. We shave off the arthritic undersurface of your kneecap, and that kneecap then plastic portion rides on the end of your thigh bone on the metal as well. So a lot of patients, rightfully so, ask, well, how long will it last? And in any one patient, we're not able to tell you how long it will last for you. What we can tell you, on average, a conventional knee replacement should last 10 to 15 years. There's patients who fail right away, infection or some mechanical problem. There's patients for around 25 years. But on average, traditional knee replacement would last 10 to 15 years. The longevity of the implant depends on many factors: correct surgical alignment, if someone was to develop an infection, and patient activity level. So one of the primary causes of knee revision, that is your knee replacement failing, needing to be redone, is wear. So as the surfaces, if you think about that picture where you have a metal component of your thigh bone rubbing on plastic, well, just a normal daily activity, you're going to have a certain amount of wear, so the metal's rubbing on the plastic. As that metal rubs plastic off, it generates tiny fragments of plastic, and that can cause irritation in soft tissues around the knee and the bone of the knee. So why is plastic wear a concern? When you have wear in the plastic, it shortens the longevity of your knee replacement. So I have patients who I had done 18 years ago who are doing absolutely fine, have no pain, everything's wonderful except their plastic's wearing out, and because of that they have to have operation. So wear can be a significant problem. Also, those tiny particles of plastic that get worn off the plastic surface, those not only can they represent sort of changes in the bearing surface of the knee replacement needing surgery, those little particles can percolate around in the soft tissues of the bone and can lead to softening of the bone. And also that softening, which we call osteolysis, can lead to loosening of the actual implant, make the knee unstable, and increase the chance of you need to have your knee replacement redone. So that brings us to Verilize. So traditional knee replacement, traditional knee materials are cobalt chrome, which is just a high-strength metal alloy, and high-density plastic. And again, as I said, the expected lifetime of a knee replacement is 10 to 15 years before wear becomes an issue for patients. Verilast, which is a knee implant technology, combines two low-friction materials. It's a combination of Smith & Nephew's oxinium and also highly cross-linked polyethylene, which is a high-strength plastic. So this bearing surface is what refers to Verilast. So oxinium is what's actually called oxidized zirconium. Zirconium is simply a biocompatible metal, similar to titanium. And the outer surface is treated and takes on a low-friction ceramic-like poly. Ceramic has extremely good wear characteristics. It's a great bearing surface. Unfortunately, true ceramic has certain incidents of breakage. So this takes on some of the wear properties of ceramic, but it doesn't have the breakage associated with ceramic. And so that surface, this combination of the oxinium, this zirconium, oxidized zirconium, and plastic, they were able to demonstrate for the FDA that as the surface becomes approximately 5,000 times more resistant to what's called metal abrasion, which the bottom sentence here it says it reduces plastic component wear by 85%. So that's a significant improvement in one way a knee replacement fails, that is wear. So again, oxinium can extend the life of your knee replacement because of wear. Incidentally, it weighs 20% lighter than cobalt chrome knee replacements. And it's safe for patients with metal allergies. So if somebody has sensitive to certain metals, and there's actually many patients that are, this would be the knee replacement of choice just based on the metal sensitivity issues. So the company went through the trouble of submitting to the FDA, and they looked at, they have knee simulators, which they can actually simulate motion and wear within an artificial knee. And they simulated after 5 million steps, they decreased the amount of wear by 98% compared to traditional implants. So that's really good. But they took it further and they simulated 45 million steps. 45 million steps is approximately 30 years of normal use. And they almost showed that they reduced wear by 81%, and that was 81% better than just traditional knee replacements can only do really back to 5 million. So what does all that mean? It means they've really stepped up their game as far as improving the bearing surface and the wear, which decreases the risk of one mode of failure in knee replacement surgery. Well, what about other modes of failure? We talked about alignment, how your knee replacement is aligned being very important. So I use what's called patient-matched technology. This particular company is called Visionaire. So there's studies that would suggest that up to 30% of knee replacement failures are due to misalignment during surgery, and that patient-specific alignment may result in better surgical outcomes. So Visionaire, patient-specific instrumentation is what we call it, uses X-ray and MRI. And the combination of those we use to create custom cutting blocks and guides that match your exact shapes and angles of your anatomy. What does that mean? If any of you have ever gone to museums and you've seen plaster molds of a face, for example, hung on a wall, which is you're sort of looking in at the inverse image of someone's face, it's unique to that one individual's face because it fits the contours in a very unique fashion. What this does, using the MRI, X-rays, and alignment in the computer system, it creates a unique mold that matches the end of your bone, the end of your thigh bone, top of your shin bone, in one specific way. And then driven off that in the computer, then we create the alignment and sizing for your knee replacement before you even get to the operating room. So here's the process. So the process is, you come to the office, we talk about your knee, maybe you have several months, years of non-operative treatment, and you decide, okay, it's time to get a knee replacement. Combination of an MRI and X-rays get uploaded, gets into the company, which goes into a computer-assisted design program. That information then gets sent to me. I go in there and we've already decided, prior to again you ever getting to the hospital, I've decided on the size of your components, the alignment, rotation, all of these parameters, how we're going to put your knee replacement, I've already decided before you even got to the hospital. That goes into a computer-assisted manufacturing program where they create these unique molds that fit into your knee. You get to the operating room with the sterile package of your patient-specific instruments, and we perform your surgery. So a little more simplified, your arthritic knee, you get an MRI, the company creates a 3D bone model, create custom blocks, instruments that fit your knee uniquely, that helps us prepare your knee to accept your knee replacement. So why is it special? Patient-specific instrumentation may eliminate time in the operating room. For me, it does. It helps decrease the amount of time that it takes to do your operation because I've done a lot of the thinking up front. I've already figured out how we want to cut, what size we want to cut, all these kinds of things that are important in the operative. We've already figured it out. So we don't have to have your incision open as long a period of time, which leads to decreased anesthesia time. That is, you're asleep a shorter amount of time. Your wounds open a shorter amount of time, which could lead to less risk of infection. It's been demonstrated there's less blood loss because your wounds open a shorter amount of time and less soft tissue work remaining. So, and that precise alignment may lead to having a longer lasting implant for you. And in summary, just so you know, physical therapy after your total knee replacement, so therapy starts the day of your operation. So that afternoon, therapy will get you up, out of bed, standing, walking, depending on how you're feeling. Discharged from the hospital anywhere from the same day to 3 days after surgery. And then you follow up in the office at prescribed intervals. So that's the summary on knee replacement. Anybody have an update on the company?
Okay.